Good afternoon, everyone, and welcome to this C1RP webinar, RSV Prevention Program Implementation in Ontario Health. Before we get started today, I would just like to start off by acknowledging that we are meeting on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years. Long before today, as we gather here, they have been Aboriginal peoples who have been the stewards of this place. In particular, we acknowledge the traditional unceded territory that our CMNRP office is located on, and that is the Algonquin Anishinaabe people, and our Kingston office, which is located on the traditional territory of the Anishinaabe and Haudenosaunee peoples. We recognize and deeply appreciate their historic connection to this place, and we also recognize the contributions all Indigenous people have made, both in shaping and strengthening our communities in particular, and in our province and country as a whole. September 30th is coming soon, and each year on this day is the National Day for Truth and Reconciliation. This day honors the children who never returned home and survivors of residential schools, as well as their families and communities. The orange shirt is a symbol of the striping away of the culture, freedom, and self-esteem experienced by Indigenous children over generations. On September 30th, we encourage you to wear orange to honor the thousands of survivors of residential schools. I'd like just to introduce myself. I'm Catherine Gascon. I'm one of the perinatal consultants with CMNRP. And later during this webinar, we will also have my colleague, Alyssa Height, presenting a bit later. We just wanted to point out that this RSV webinar might be a little bit different than what you have seen in the past. So the goal of today is really to summarize everything that you need to know to support the successful implementation of RSV. So we will review very high-level information about Abrysvo and Beyfortus, but we wanted really to share existing resources to support the implementation and really identify any additional opportunities for support. So before I get started, I just wanted to see if we could do a Zoom poll question. So you should be seeing something pop in front of your screen just to see who is attendance today. So we will ask to share just your profession, just by curiosity, and also the setting of where you work. So do you work in a hospital, community, or more public health? And I'll give you a bit of time just to answer those. Excellent. So if we share the results, we can see that we have a lot of nurses attending today, so about 38%. We have a family physician, a pediatrician, some midwives as well, directors and managers, and some others as well, so which is great. And we wanted to know where you work mostly. So a lot of you are working in a hospital settings, public health as well, and then we see community and a lot of others as well, so 11%. So thank you so much for sharing. This is just helpful for us to know who's in attendance today. So the first thing that we wanted to show was to remember, we all know what RSV is. RSV is a major cause of respiratory illness, especially in young infants, young children, and older adults, and we know that it affects the lungs and airways. We also know that RSV can have an impact on families and the healthcare system by making emergency department visits, hospitalizations, and ICU admissions increase. So the goal of the RSV Prevention Program is really to provide protection to those high-risk infants, protect individual health and health of families and communities, and also protect and mitigate impacts on our healthcare system. But if you're like me, you may wonder how much of the RSV program will represent in terms of who will that speak to. So the next slide will give you a bit of their very, very rough estimate numbers of how many babies will we see go through RSV implementation. So this slide has been modified. It comes from Kids Come First. In terms of, we just looked at the number of births that we usually see here in Ontario Health East. So this would be including Champlain, Southeast, and Central East. Roughly, there would be 14 14,000 babies who are born outside of the viral season. So those would be the catch-up babies that we would ensure that they need access to immunization. The 12,000 babies are the ones that would be born during the viral season. So those are the babies born in hospitals that we could immunize at the time of birth. And out of these 26,000 babies, about 400 will be high risk. So considering the second season, if they're still high risk. So this is a rough estimated number, but it just shows how many babies in general would probably go through this year into the RSV immunization program. So the first thing we wanted to do with you today is to talk about what we already know. So we know that the Ontario Ministry has expanded the program by making sure that all infants, including those high risk, up to 24 months of age. We also know that there has been a switch from Synagis to Beyfortus in terms of the monoclonal antibody. Of course, the ministry will cover the full cost of Beyfortus, and that this is generally within the active season of viral season. So November to April, epidemiology often will confirm dates specific. So that's why I don't think that those dates have been communicated yet. But this is the usual viral season that we will see more actions with RSV. Talk about the 3 eligibility criteria. So within the next slide, we want to make sure that everyone is aware that eligibility criteria for us is residents of Ontario. There's 3 different scenarios. So the first one would be a baby born in 2024, but before the RSV season. So we also know that the National Advisory Committee, so the NACI, has recommended that infants less than 8 months or less should be immunized. Now, I think that was a popular question that all popped into our mind when we started getting ourselves ready for RSV would be babies who are born, let's say, in January or February of 2024. If you're doing the math, they would be older than 8 months. So are they still eligible for the RSV program at that time? And with the ministry webinar and information, it was shared that yes, they would be eligible, but to still follow the NACI recommendation that, you know, infants 8 months of age or less should be immunized. The second scenario would be the babies who are born during this viral season. So those would be the babies mostly in hospital, but we'll talk about different scenarios when they are born at home or within the birthing center as well. And then the third scenario or the criteria is that our children up to 24 months who remain vulnerable. So those we call high risk, and they are at their second season of RSV. So the next slide will just remind us what do we mean by those high-risk babies. So they are babies who would have chronic lung disease, they would have congenital heart disease, Down syndrome, cystic fibrosis, and other anomalies that you can see here on this slide. So I won't spend a lot of time reviewing them all, but just as a reminder that these are your high-risk babies. The next slide where we wanted to sort of summarize is what we know so far for vaccination in pregnancy. So we also know that the ministry has made the RSV vaccine of Bristol available for pregnant residents of Ontario. We know that it should be given from 32 to 36 weeks gestation and planning that this person will be delivering during the RSV season. We also know that the NACI recommends that Beyfortus is the preferred product compared to Bristol due to its efficacy and duration of protection. So really what we're saying is that Bristol should be considered on a case-by-case basis. So if you're in a situation where the pregnant person would decide to go with a Bristol, there is no additional benefit to using both a Bristol and Beyfortus for the baby as well, unless there is some situation where a Bristol was given and the baby is born less than 2 weeks, or when the baby is born, if the baby is high risk, then that baby would still need Beyfortus, even though the pregnant person had received a Bristol in pregnancy. And I think one of the main questions that was coming up for us healthcare providers was that is it okay to give Abrysvo if it is at that specific situation to give it with other vaccines during the pregnancy, so such as Tdap, COVID-19, or influenza vaccines? And the ministry has given us guidance that yes, it's okay to give on the same day as other vaccines as well. The other question that was often come up is the question that, okay, so we know that this is the Ministry for Ontario, but what about babies that are born in Ontario, but that do have a Quebec address? So we have, hospitals that are close within our region that they would have a Quebec address, but they're coming to an Ontario hospital. So there can be many different situations from Quebec and Ontario, but the one that we know that is the same criteria is the babies that are born during the viral season. So that specific criteria or scenario is the same for Ontario or Quebec. So the ministry has said that they're still working on the process for reimbursement, but it could be, they're saying that, officially a baby that is born in Ontario, but that has a Quebec address, we could be okay to give Beyfortus if the parents and patients choose to do so. But the ministry will share more information about the process behind reimbursement if it is different from Quebec to Ontario. Now, there might be other criteria on the Quebec province that are not the same. So the catch-up babies or the babies that are a little bit older, the ones that, up to 24 months, but high risk, they may have different criteria than us here in Ontario. But the ones that we know is the babies born during this viral season, the criteria for eligibility is the same from Ontario, Quebec. So that's why that we say that those babies could probably receive Beyfortus even though they're in an Ontario hospital, even though they have a Quebec address. Excellent. So this was the part where we wanted to review and summarize the information to you. Now we get into the actual implementation. And the way that we have it set it up today is that we really want you to take sort of a step-by-step process. So the first thing that we would think of when you're thinking about the first step would be your antenatal implementation. So when you're looking at your antenatal implementation, the first thing that you would talk about is, where do I get Abrysvo? So even like the supply of it. So we know that currently Abrysvo is available. We've heard that some hospitals have been able to provide them, to provide it. So this is the way that you would order Abrysvo is through your local public health unit vaccine ordering process. The main message that we want to throw to healthcare providers is, when do we actually start the conversation about Abrysvo? So it would be, for us, a good timing would be anytime we're discussing any vaccines during pregnancy. So the first thing that came up to our mind is when you're talking about Tdap, it would be a great time to talk about Abrysvo and Beyfortus, and to have the conversation with your patient at that time that Beyfortus is the preferred product for the infant. Now, there could be a situation where the pregnant person is really wanting more the vaccine during pregnancy. So we need to make sure that we have informed consent for that patient and that they understand the risk and the benefits between Abrysvo and Beyfortus as well. So as I mentioned, it can be given with other vaccines, and it would be administered between 32 to 36 weeks. The thing that we want to make sure that we sort of promote is getting information to families. So you may have seen PCMCH pamphlets, or what they call the fact sheet. So they have a fact sheet. One is more for healthcare provider, but the other one is more for families. So making sure that if we could direct the families to, have access to those information. So it would be nice for them just to have a bit of a pamphlet with information about questions on both as well, so that they remember the information that we give to them. The next slide will talk us through. So now we've decided that we're going to move ahead and the pregnant person is wanting to have Abrysvo. So where could it be given? So it could be given in the hospital. It could be given in a clinic where patients are seen by their family physicians or OB. Their clinics might be outside of the hospital. And same thing with primary care providers. So some primary care providers will do the follow-up of the pregnancy within the first and second trimester. And if those primary care providers were able to order vaccines, it could be a place where they would receive Abrysvo. Now, as a reminder, we just wanted to make sure who can give a Briscoe. So any physicians, any nurses, nurse practitioner, registered nurses, or practical nurse can give a Briscoe. And midwives, they are able to give a Briscoe to the pregnant person. And you may sometimes find a pharmacy, again, who would have a stock of a Briscoe. So it could be another location, possibly, that the pregnant person can find access to a Briscoe that way. Now, the next piece is a really important one as well, because we want to make sure that once we've decided to move forward with the administration of Briscoe, we need to communicate effectively with healthcare providers that it was given. So the documentation piece is really important, and we want to know what was the date of the administration. We want to document if there was consent that was obtained. And here's where you would have many different avenues within your organization to choose where do you document that a Briscoe was given. So it could be your hospital record, it could be through your electronic medical record, so your EMR. You may be able to have a discharge summary printed off from your EMR that would include, the care the patient receives, or Briscoe, the date that it was given. So ideally, if you can print off a discharge summary and give to the pregnant person, we'll show you an example of the Ontario perinatal record, because that could be an idea where you would document that a Briscoe was given. And later on during the webinar, we'll also show you the born documentation piece of it. So that's why this slide refers to where applicable, because it would be your organization choosing which is the best place to really document that a Briscoe was given. And we wanted you to think about reporting it, right? So how do we make sure that the communication gets to other healthcare providers? So patients could use the Can Immunize app. They could use their personal immunization record, the yellow card, or sometimes the old way of referring to it was a passport. So the image there just shows you that personal immunization record, but it could be through making sure that your primary care provider is aware as well that they have received a Briscoe. I think the important piece here is we want to make sure that we know if a Briscoe was received, yes or no, because this could help decide if the baby gets Beyfortus in hospital as well, right? There may be some situations or cases where we're unsure if the pregnant individual had received a Briscoe or not. And the ministry has given us a bit of guidance to know that if it's unknown, it could still be offered Beyfortus to the baby at that time. So the next slide will show you just an example when I was referring to maybe documenting it in your OPR. So the page 3 of OPR does have a discussion topic segment. It goes through, your first trimester, second trimester, third trimester, and gives you a bit of just an idea of where you can possibly add the documentation of a Briscoe being given. So we know that this is a standardized document that is used for all patients going to the hospitals to deliver. So it could be one of the spots that your organization chooses to document it as well, so that it would be evident in that sense. Now, I think within the step process of continuing on our pathway, I'll ask Alyssa to speak about when we get to the postnatal implementation and just take us through what would be the implementation at that point.
Thank you, Catherine. Hi, everyone. My name is Alyssa Haight. I'm also a perinatal consultant with CMNRP. So as Catherine said there, I'm now going to take you through that postnatal implementation. So this is really going to be looking at how we're going to implement the RSV Prevention Program for the infants. So when they're going to receive that RSV monoclonal antibody for, or also called Beyfortus. So this may look familiar to some of you. So this is that PCMCH fact sheet that is actually for providers. So there's some key information on here that I'm going to actually break down for you. And we're going to go through different types of ways that we're going to be giving Beyfortus, or different types of scenarios that it will be applicable. So there's different channels that we can reach these eligible populations. So we may be able to hit certain eligible babies while they're in hospital. We may be able to also get others who are born at home or in a birthing center. And then, as Catherine said, there's going to be those babies such as catch-up babies, so born earlier in 2024. So I'm going to walk you through that scenario as well, and some strategies to try to get those babies, as well as the children under 24 months who are at high risk and we're maybe getting that RSV monoclonal antibody for their second season. So next then, there are a few different scenarios that it's important for us to review of when a pregnant individual has gotten a Brisvo, that the infant is also going to be qualifying to get Beyfortus. So those scenarios are going to include infants who are born less than 2 weeks after that gestational parent has received a Brisvo. So we just haven't had enough time for that passive immunity to get to the infant. So they will also get Beyfortus after delivery. Another situation is maybe after that infant has been born, they've been identified as high risk. So they now have additional medical criteria that puts them at increased risk for a severe RSV infection during that season. So we want to give them that extra immunity and also offer Beyfortus to them. There may then be scenarios where that pregnant individual doesn't know their vaccine status for a Brisvo. So Catherine did talk about how important it is to keep those records and to make sure that the individual is aware of their vaccine status. But if they are unaware, the recommendation is still to go ahead and give Beyfortus to that infant. But one consideration that you might do within your organization is adding that question to an admission checklist or admission questionnaire to ask their vaccine status for a Brisvo. So the first scenario that I'm going to take you through is administration of Beyfortus within a hospital. So we're going to be talking about a hospital birth for an infant who was born during RSV season, so this upcoming fall. So it's expected that the supply of Beyfortus should be available in mid-October, which is really great timing because we know that the beginning of the season is anticipated to start sometime in early November. So that gives us time then to order the product, have it in place, and get ready to start administering at the beginning of that season. The way that Beyfortus is going to be acquired is the same as any other product, even same as a Brisvo that we would get through our local public health unit through the vaccine ordering process. So that is unchanged there. The organization may think of creating a pre-printed order, whether that be incorporated into your electronic medical record or paper documentation, or creating a medical directive to capture all of that newborn population and have the Beyfortus dosing built right into that. It is important once we start talking about administering Beyfortus in hospital that we know the key messages that we want to portray to families. And we're making sure that they have a good understanding of what Beyfortus is. So as Catherine had described, hopefully these discussions have started in pregnancy and they were aware of the differences between a Brisvo and Beyfortus. We want to make sure a couple extra features are captured in this education. And we want to give that Beyfortus ideally just prior to or during the RSV season. And it's important to remember that it's going to be most effective for the first 6 months after it's given, which will then last the duration of that RSV season. It can also be given with other childhood vaccines or influenza vaccine as well. Because we are going to be administering this to their infant, we want to make sure that they are informed about the product, about RSV in general, and that we obtain that informed consent. There are additional pamphlets available and handouts if families are looking for more information or are looking to have this truly written out for them. A great example of that would be the PCMCH pamphlet, and that's the one that's specifically available for families. So there's one that's separated for healthcare providers and then as well for families. So we're going to further go through this scenario. So we want to think about when do we want to give Beyfortus in hospital. So the ministry's direction has suggested that we give it before discharge. So we want to try to capture that hospital admission, administer before they go out into the community, especially when they're born in that RSV season. So some special considerations that you may want to incorporate into your practices at each of your organizations are going to include completing that point of care assessment to consider if there's a specific time during their stay or with other scheduled care that might be the most appropriate to administer Beyfortus. So what that could look like for your organization is you could actually give your Beyfortus with vitamin K. It could be done when you're doing your newborn screening, when you're doing the critical congenital heart disease screening, or screening for hyperbilirubinemia. Each of these care practices are done before discharge. An important key point to keep in mind here is going to be making sure the family has had time to receive the information and give informed consent prior to administration. Each organization may have different ways that the actual supply of Beyfortus reaches the floor or the unit specifically. So we want to keep in mind then what the pharmacy hours of operation are. So if you're in an organization that pharmacy is not open for 24 hours a day, then it might not be appropriate for us to be giving it exactly a vitamin K timing or newborn screening. So we might want to just adjust the timing then with that in mind. Another suggestion of when it could be given, so thinking of that care pathway while they're in hospital, is we could actually then tie this with their newborn assessment that's completed by a physician prior to discharge. If we do it with this care interaction, it gives us an opportunity to have those discussions, provide all the information to the family, answer any potential questions. So we're really getting that informed consent. And then if your organization hasn't had an opportunity to create a pre-printed order or a medical directive, we could get a direct order at that time for administration of Beyfortus. Another special consideration to keep in mind would be those infants who are preterm, so within maybe a special care nursery or a neonatal intensive care unit. So specifically, I'm thinking of babies that are less than 29 weeks of gestational age. We want to administer that Beyfortus shortly before they go home. If it's not available, then of course we want to get it done very quickly after they've been discharged. But the timing of when we give it, we want to keep in mind that ideally this is administered when they're greater than 32 weeks for a postmenstrual age or corrected gestational age. And also keeping in mind that Beyfortus is most effective for the first 6 months after it's given. So if we're able to delay that Beyfortus administration until slightly before discharge, the baby will have the most value of protection in the community after they've been discharged. So next, we're going to look at who can give this. There are a few key differences here between Beyfortus and Abrysvo that it's important to take note of. So physicians and nurses are still able to give this, including nurse practitioners, registered nurses, and registered practical nurses. Midwives are able to administer Beyfortus if they have a medical directive or a direct order. And this is because Beyfortus is the monoclonal antibody and not a vaccine. So it's been excluded from the list of their designated drugs and substances that they're able to order to deliver. Another key difference here is that pharmacy professionals are not able to give Beyfortus. So this is going to just kind of review some of the information that Catherine had hit on as well about the effective communication. So we really want to be sure that across the continuum of care for this infant, that all the healthcare providers involved are aware of their history with Beyfortus. So was this administered and on what date? We should also be documenting if there was consent obtained. Other key pieces that we might consider updating documentation would be if we have a hospital paper record and your electronic medical record. The discharge summary is a great option to add in this piece, especially if we're able to print a copy of that and send it with the family so they have that direct date written down and a reminder that it was given. And of course, before discharge, we want to make sure that the born information system has been updated as well. So wherever those are applicable for your organization, we want to try to hit those points. And likewise, we want to make sure that we're reporting as well. So some suggestions could be the Can Immunize app. Families can download that and add it in there. I wanted to quickly touch on the personal immunization record. So most of our infants aren't going to have that vaccine passport or immunization passport right away, but it might be an option for your organization to order some of these in and give them to parents so that they're able to have that date recorded, and then they can carry that on throughout their infant's ongoing vaccine schedule as well. It is important to note, though, that Beyfortus is not a vaccine, that this is the monoclonal antibody, so we would be using the immunization passport to include that within there. We also want to make sure reporting it to the public health and their primary care provider. So if you have documented it in that discharge summary, and a copy of that is going to your primary care provider, the family has record, and so does the primary care provider. It's important that parents are keeping a record of this dose and when it was given, and this is to avoid a potential second dose. So in an event that maybe this infant did get 2 doses of Beyfortus, if that does happen, the infant needs to be monitored because there can be an increased risk of adverse reactions. In that case, then they need to have symptomatic treatment provided as appropriate. So we know when infants are within a hospital, sometimes there are reasons that they need to be transferred to another organization. So it's important for us to also review that scenario. So if they are going to be transferred, there's a few considerations that we want to think of. Can we give it before they transfer out? Is this going to delay their discharge or transfer out? Is the infant unwell and that's why they're being transferred? So maybe we should delay the dose of Beyfortus? Or are there any other clinical recommendations that we want to consider that might actually help protect this infant against RSV before they transfer? So an example of that could be maybe an infant who is in an NICU setting and is being transferred to a pediatric unit, potentially during RSV season. So that infant would then benefit from having Beyfortus prior to that transfer. And then, of course, we want to make sure that we're communicating this with the receiving hospital or organization. So this should be then done in our discharge summary, be done in our handover or report to them. And we want to make sure as well that the born information system correctly captures the status prior to discharge, so whether it was received or not, and the reasoning of why it may not have been received. So let's look a little bit further then at the born documentation. So within born, we have the information system has some updated data elements to help us capture this season's RSV prevention. So these new changes are expected to come into effect in November, so the beginning of our RSV season. You'll see that there's going to be elements that include the prenatal vaccine, so a Brisvo administration and when it was given. It'll also include the infant RSV antibody or Beyfortus administration and the date that it was given as well. And it also has a section for if the Beyfortus was not given, it is asking for a reason of why it was not given. And if there's any additional high-risk criteria to try to capture those infants that will be applicable or where it's applicable for them to receive it for a second RSV season. So this slide was taken from a recent webinar that was hosted by Born Ontario. And here you're going to see some further implementation strategies. So this might include developing a process to remind or flag for Beyfortus administration. So certain suggestions then would be by having RSV orders. Maybe you can set a reminder within your electronic medical record. We could add this to newborn documentation checklists or discharge checklists. And it could be as informal as adding this to a patient whiteboard within the room that whether it's been done or not, or if it's been discussed. We're trying to collect all of the RSV information for every infant. within your organization or within your practice. And the information that we're looking to capture at discharge, then it's going to include the date that it was given, the reason if it was not given, that additional high-risk eligibility if applicable, as well as if there's a Bristol administration during pregnancy and when. So those key pieces can be added into discharge notes or a discharge package that may be given to families. So we're going to move to a different scenario now. So now we're going to look at babies who are still born within our RSV season, but maybe they're born at home or within a birthing center. So as I explained, midwives are going to need a medical directive or a direct order to administer that. So there may be considerations there of partnering with public health, with local hospitals, or an example as the Ottawa Birth and Wellness Center. Some of this information you'll see is repeated, so I'll just quickly touch on some of these pieces. We still want to make sure that the family has a clear understanding of Beyfortus, the benefits of that, so we're obtaining that informed consent. We're going to give it just prior to or during the RSV season, and it's going to still be most effective for that first 6 months. We're going to ensure documentation and reporting. It's in the same, I'll touch on the same piece here with that personal immunization record. If you have chose to give this to the parents, we just want to make sure that we're specifying that Beyfortus is not a vaccine, but it is a nice place to document and have that piece of information with them. So when we're talking about Beyfortus, we're talking about giving an intramuscular injection to our infants, and we just want to be sure that we also consider pain reduction strategies. So some of these strategies you'll see listed here. There are 2 QR codes here listed on this poster. So one is going to be our CMNRP self-learning module about newborn pain management and some practical approaches for that. And the other QR code listed here is a YouTube video from CHIO about sucrose and to be sweet to babies during painful procedures. And you'll find those links as well in the chat. And you can see here some listed key differences between the different strategies. So if we're doing breastfeeding for pain reduction, ideally we're starting that at least 5 minutes before the procedure. Skin to skin, we want to start that before the procedure as well. Ideally, if we can give 10 to 15 minutes prior to, so we're able to get the infant and the parent fully relaxed, we're going to have our best effects. And then sucrose administration is included as well. And we can give that 1 to 2 minutes before the procedure and then throughout as needed. So the last scenario that we're going to look at is those infants who are qualifying for Beyfortus for additional eligibility criteria. So we know that infants who are Ontario residents are going to qualify if they were born in 2024 prior to this year's RSV season. So we're talking about January 2024 up until the beginning of our season, anticipated this November. As well, babies who children who are up to 2 years of age who remain vulnerable for severe RSV throughout their second season of RSV are also going to be eligible. And as Catherine mentioned, the key difference here with the initial NACI recommendations and what the Ministry of Ontario has decided to do for this RSV season is we are increasing that 8-month recommendation from NACI to all infants born in 2024. So for this population, it's really important that we're getting that message out to families, that they understand that their child needs to have Beyfortus, and we get this message to them. So a great way to do that would be when we're seeing them for any childhood visit, whether this be a wellness check or routine vaccinations. Places where we can give this could be with the primary care provider, or it could be through your local public health unit. And we can see that there'll start to be some possible clinics and partnerships with more information to come as the season gets closer. So when are we going to give it then? So ideally, we're going to give it shortly before the beginning of that RSV season, but it can continue throughout the RSV season. So just because we haven't caught them just before or right at the beginning, we can continue to to try to administer this throughout the season as well. We know that Beyfortus can be administered on the same day or anytime after, before or after childhood vaccines. So there's no need to space it out between different vaccines, and that includes influenza as well. So you can see here different opportunities that we may capture those babies. We can see that they could be captured at their 2, 4, 6-month immunizations, or those babies who are at high risk and going into their second RSV season, they may be captured at the times of their 1-year, 15-month, or 18-month immunizations. Who can get Beyfortus is going to be unchanged, so it's product dependent, not location dependent. So you can see here that nothing has changed, so it's still physicians, nurses, midwives are still going to need a medical directive, and pharmacy professionals are still unable to give Beyfortus, even though they're an older child. And our documentation is really going to be unchanged as well. It's important that we have documented the date and the dose, the consent, and that we've reported it appropriately as well. Now, when we talk about the personal immunization record for these infants, it's more likely that they will already have that established, so we can add it to that record for them and keep track of it. One of the special considerations we want to make sure that is not forgotten is about those high-risk infants. So we may be capturing a high-risk infant for their first RSV season this fall, but we need to make sure that the families understand that they could potentially then qualify for a second RSV season and will need to receive it again next year in the 2025-2026 season. So you've heard me talk a lot about consent, but I just want to make sure that we also, in talking about informed consent, we want to make sure that the family has been adequately informed, that they have been given all of the information needed to make that decision. Make sure that they understand the differences between a vaccine and a monoclonal antibody. It's also important when we're talking about consent that they understand what RSV is and what the risks are associated with that, and the risks then associated of opting out of receiving Beyfortus. So what this may look like is if family is deciding to opt out of Beyfortus, we want to be sure that some counseling is done around how to access it later. So maybe they've initially opted out at this point, but they want to go back home and think about it and try to, and they may come up with a different option and decide that they would like to give it at that point. So a great way to ensure that they have a second opportunity to revisit these discussions is to make another follow-up appointment so that they can revisit these discussions and decide if they truly want to opt out. And different organizations may then decide to create a refusal document that just has some information about Beyfortus, the risks of RSV, and including some information from the family signature and date as well. So now I'm going to pass it back to Catherine, and we're going to do a little review of all the things we've gone through.
Yes, to sort of summarize everything that has said today, I think it was important to share this piece of the pamphlet from PCMCH. So again, this is in the provider one, but the big message that we are still asking ourselves the question is, how will this message be even communicated to families and patients that they are eligible to receive RSV? So we are not 100% sure yet, as there's not been like a communication or different, like a ministry communication message that will be shared that way. But I thought that this piece of the pamphlet was just great for healthcare providers to know what should we be talking about with our patients and families. So, you know, reviewing what is RSV, what are the immunization options, that Beyfortus is the preferred product, but also talking about preventing strategies. So avoiding close contact with sick individuals and making sure that we do a good hand hygiene and those types of things. And the biggest piece will be the documentation. So how do we make sure that we know that everyone is aware that we have received a Bristol or Beyfortus, right? I think a lot of the roles will be through public health communication as well. And the next slide goes to show you what are the websites for these public health units. So we, CMNRP, are in contact with public health units, but they're still working out their programming and the way that this will be divulged to the public right now. So we know that some of these health units will be providing RSV clinics during their regular clinics, but all the details have not yet been shared because, again, as I said, they're still working on it, right? They will be doing a little bit of promotion and more information will come. So in the meantime, what we have done is we have put the public health units that are within our Ontario Health East here, and we've linked the websites either through their immunization page, or if they already had an RSV web page within their public health unit, then we have linked those as well, so that hopefully you can use those links. And as more information will be shared, then you will be able to get some of those through those links. The other way that you can stay up to date is through our weekly news. So weekly news is an email that we try to share many information, but a lot of it lately has been on RSV. So anytime you would have an update on RSV, you would receive a weekly news that would include those information. So if you're not registered to receive our weekly news, you can do so with the CMNRP info at cmnrp.ca, and we will put the email in the chat box just in case you want to register for those weekly news. And the link at the top of this screen, so this is the public health unit locations. We'll share that in the chat box as well, just making sure that if you're unsure which, underneath which public health unit you would fall based on your locations, that is a list of all the public health units. And then you could even put like your address and it will help you decide or let you know in which of those public health units. So it's a little bit too early to know all the details of public health. They're working very hard in getting those to us, but in the coming weeks, I'm hopeful that we will get more information as well. And then we wanted to finish off with key messages. I will not speak to this slide. I think we did a lot of their time in speaking to those key messages, but just making sure that if you want to read them off, those are like the important things that we want to remember. I want to leave a little bit of time for questions and answers as well. So the way that we have set it up is that we want to make sure that you have the resources available to you. So the next few slides will go through resources for healthcare provider. And we have sort of divided them for healthcare providers and families as well. So these are the ones that are more for healthcare providers in a general format for RSV typically. And there's good conversation guide, because it's hard for as healthcare providers to have the conversation about if there is hesitancy for the vaccines, if there's hesitancy with the treatment as well, how do you make sure that you are providing a good informed consent without coercing the patient to receive any treatment or what so forth. So I think those are helpful links for you. The second page is still for healthcare provider, but these are meant a little bit more for physicians in terms of SOGC statement about vaccinations and how to bill. That is a question that has come up in other webinars as well. So you as a healthcare provider, if you're providing the Briscoe or anything like that, how would you bill? How would you counsel? So there was a little bit more information on the OMA webinar if you were able to attend that one in terms of this, but we thought we would put out the links. And then the final one is for families. So the resources for families come from the ministry, PCMCH. There's a lot of great information on Canadian Premature Babies Foundation, which we have linked here, and again through Born. So Omama website is a great resources from families, and they can have the app on their phones as well. So those are the types of resources that we can share. And again, as we alluded to, the fact sheets or the pamphlet from PCMCH. So we wanted to leave a little bit of time for questions, and I see that there are some questions in the Q&A, and we'll get to them shortly as well. But I wanted to take the opportunity to identify any additional opportunities for support. So let us know if you want more information or if you need to know something else, please let us know, and we can see if we can help you figure out your process or if we can help you find those information. But I'll ask Alyssa just to take us through a couple of questions that we are seeing now through the Q&A. So thank you for providing those questions ahead of time as well.
Great, thank you, Catherine. So one of the questions here is, will there be a more robust communication campaign for families, particularly thinking about unattached parents or infants, and those who have a primary care provider but are unhappily attached and do not attend regular visits or are therefore missing out on the messaging?
Yeah, that is a great question. I think in terms of spotlighting campaign, there's not been like an official campaign. I think public health will help spread the message, but that is a lot of it. The concerns that we are having, we're relying on word to mouth, we're relying on families, making sure that they have the information. But what about the babies that fall through the cracks? So those babies that are unattached, that don't have, a healthcare providers, that's exactly what we're unsure yet of how will this be communicated. And it brings a really great point to make sure that we have a more robust process to see that if we can capture those before they fall to the cracks and that they're not forgotten as well. So it brings up a really great question that I unfortunately don't have an answer particularly for it, but something that is always in the back of our minds to make sure about those unattached babies for sure.
Great, thank you. Next question is two questions combined here. So are we going to make this presentation available afterwards? And will the recording also be available for anyone who is unable to attend?
Yes, so the recording will be available through the CUNRP website. So what will happen is that we'll upload it through the CUNRP website and our YouTube channel as well. So, but I will say maybe by the start of next week, we're getting to the end phase of this week as well. So I'm hopeful that we can maybe get it out to you by the end of this week, if not early next week. But yes, the recordings will be available. And if you, I'm seeing that there's also interest in making maybe the PowerPoint slide, so we can make that available through the registration process as well. So we have your email communication that we can maybe share the slides PDF if that is of interest of participants for sure.
Great, thank you. And then just going back to our infants that were born in Quebec and their eligibility, there's a question here about getting infants or patients from Iqaluit, saying that they get probably just as many from there as they do from Quebec.
That is the question that I am unsure of. I will have to dig a little bit deeper. I don't know, Alyssa, if you have more information. I'm a little bit more aware of the Quebec, criteria. I didn't take a look or didn't have a chance to get through the Iqaluit and if it would be the same, process. But it's a really great point to bring back to us. So thank you for bringing the question. We will dig a little bit deeper and try to see if we can find an answer. Would it be the same process? Because if you're getting a lot of those more northern, patients coming into Ontario to deliver, would that be the same that Bayfortis could still be administered to those baby, even though they haven't dressed from another province? So that is a little bit more guidance that we'll need to double check with the ministry as well, unfortunately.
I agree. There was a second question as well about infants who are born in Nunavut. And I think that it's going to depend on each of the other provinces and territories and their recommendations or their eligibility criteria. And if there is that overlap, then there may be the same exceptions that are made with those Quebec address patients. We have some information here in the questionnaire answers as well. So we have that the Kids Come First is going to be offering RSV through their Vaccinate and Up to Date program for unattached babies. And there is a link here as well. So I can share that in the chat for anyone who's interested as well.
Thank you for sharing.
And then another question we have here is about NICU transfers. So for example, TO or TOH to the Queensway. Should we ensure Bayfortis is saved for the discharging hospital to give for ease of the process and clarity for who gives it? So I think that's going to come down to the age of infant specifically. So it depends on what gestational age the transfer is happening. The recommendations through the ministry documents suggest that we should wait to administer Beyfortus until a postmenstrual age of at least 32 weeks. So I would suggest if you're transferring before 32 weeks, that this is communicated to the receiving hospital that it has not been given and can be given closer to discharge. I think likewise with that, even if they are above 32 weeks, but are anticipated to stay in hospital for an extended period of time, it may be best to wait a little bit closer to discharge so that they get that maximum amount of that 6-month efficacy in the community versus in an NICU setting. And this is assuming that that infant is transferred from NICU to NICU or NICU to a special care nursery and not a pediatric ward.
Awesome. I don't see any other more questions, but I will leave you a couple of seconds or minutes just to go through the questions and see if there is anything else popping up. We do have the CUNRP info at CUNRP email on the screen right now. So if you think of any other questions or concerns that you didn't get a chance to address today, we would love for you to send it through that email, and then we can see how we can help you towards that way as well.
Yeah, there's just one other additional question here. So looking at implementation strategies in our province, and this person has said that they'd be interested in collaboration with other provinces. And how would we connect then with other province leads of their implementation strategy?
I think that is a question that we'll have to bring up to, higher management in terms of seeing if that would be possible through your provincials, programs, but it's a great idea as well in terms of sharing, processes within provinces. It might be a little bit difficult if the criteria are not the same. So that's why we have to be a little bit more careful in terms of eligibility criteria, but definitely that's the whole point as well, is sort of sharing the processes that you have put together to see if it can be applicable to others as well. So if you have, any medical directives that you have already started and then you want to share with us, that we can share with others and just sort of not reinvent the wheel and make sure that we have those documents sort of useful for everyone. That is the point as well.
Great, thank you. Another note here as well that FEO will be administering injections to high-risk children followed at FEO for their first and second seasons. So that's great to hear. I think kind of ties into another question that's listed here about how are we going to track those high-risk babies for their second season. And we really need to make sure, again, that communication piece is there. So we want to make sure the family is educated, but that whoever has deemed that this child is high risk, that whether it be their pediatrician or their primary care provider, that they are educating the family and promoting that they get it for the second season. They can track that and help educate on where to receive it for the next year. Anything to add to that?
No, sorry, I was trying to find my unmute button, but I wasn't fast enough.
And lastly, we have, is it our responsibility to inform public health, or is it the parents? I think this is maybe a vaccination status or Beyfortus status.
Yeah, you can go ahead, Alyssa. Sorry, I didn't want to interrupt.
No, go ahead.
Yeah, I think the responsibility comes from the parent. So it is the parent's job to make sure that their, immunization status for their infant and newborn is up to date. So same thing, the communication when you go to your family doctor, not all families know that this is not being communicated to public health all the time, and just making sure that that information is being done through all the proper channels, right? So you go to your primary care provider and then you assume that it's, shared through public health as well. So it's just that added extra layer to make sure that you're documenting and reporting it through the Can Immunize to your local public health unit, because when they get a little bit older and then they get to, start of school age, then immunization will have an effect on maybe the eligibility to go to school or things like that. So I don't know if you have any more information to share through that process, Alyssa, and if I'm
No, I
really answering.
completely agree. It would be the same process as routine immunizations now. So they should be keeping records themselves and passing that on to public health.
Excellent. So I see that we're at I said 4. This is 14:01 to 2:01 p.m. So we're at the end of our webinar, and I don't see that there's any more questions, Alyssa. But if there are any more questions and we didn't get time to answer, we will try to answer them through the CMNRP info. You can always contact us. As I said, the recording of this will be available through the CMNRP website and through their YouTube channels as well. So we are always available to answer any questions if you have some more. And we would like to thank you for your time in participating today. We know that everyone is so busy and the fall is getting busy and busier with RSV coming in shortly. So thank you all for your time and appreciate the networking opportunity today.
Yes, thank you. And just to clarify on our last question that we had there, we did have an additional comment popped into the questions here, just saying that because it's not a mandatory vaccine, that it's not a requirement of the parents to report it, but it is a great process for them to follow, and they can actually update their Can Immunize app as a way of reporting as well.
Yes, thank you for that reminder.
Thank you.
Thanks, everyone.
Thanks, everyone.